Hi, everyone. Thank you for joining us tonight. It's a couple minutes after 7, so we're going to go ahead and get started. You've all connected to our webinar, our final webinar of the year, and that's on ear, nose, and throat issues in the ectodermal dysplasias. Dr. Raj Sindwani is a member of the NFED Scientific Advisory Board, and he's going to present our topic to you tonight. And I'm just going to read some information about Dr. Raj Sindwani. If you haven't met him in the past at a family conference, this gives you a little bit of background about him. Dr. Sindwani graduated from the University of Western Ontario School of Medicine in 1997, and then he completed his residency in otolaryngology at the same institution. He went on to do a fellowship in rhinology at the Massachusetts Eye and Ear Infirmary, Harvard Medical School in Boston. And he's certified in both Canada and the U.S. and is a fellow of the American College of Surgeons, the Royal College of Surgeons, and the American Rhinologic Society. He's the head of the section of rhinology, sinus, and skull-based surgery of the Head and Neck Institute at the Cleveland Clinic Foundation, and is also the Institute's Quality Improvement Officer. His editorial functions include editor-in-chief of the Yearbook of Otolaryngology, associate editor of the American Journal of Rhinology and Allergy, and member of the editorial board of the Yearbook of Otolaryngology and the ENT Journal. In addition to serving as a reviewer for premier publications in otolaryngology, neurosurgery, and ophthalmology, he also serves on several scientific advisory boards, such as the NFED. And Dr. Sindwani is considered a leading authority on the medical and surgical management of sinonasal disorders and has pioneered endoscopic surgical approaches to the frontal sinus, sphenoid sinus, and orbit. And he's published extensively in the field of rhinology and has lectured at many institutions, instructional courses, and scientific meetings around the world. And as we say at the office, he is our expert on snot and boogers. That introduction, we will have an opportunity for some Q&A at the end of Dr. Sindwani's presentation, and please feel free throughout the presentation to go ahead and instant message your questions in the chat box that you see on your screen, and if that way you won't forget them. If we don't get to any questions tonight, we will certainly try to address them by email. And you can email the office with additional questions at info@nfed.org. Tonight's call is being recorded, so you can also access the recording at a later date. A link will be posted on our YouTube, and we'll have one emailed out as well. So with that, I'm going to turn things over to Dr. Sindwani.
Okay, thanks, Kelly, for that very kind introduction. And I recognize some of the names on the chat on the sidebar here as far as who's here, so that's good to see that people are interested in ear, nose, and throat issues related to the ectodermal dysplasias. The talk that I'm about to give is a truncated version of one that Tim Fate and I have given for several years now at the NFED Family Conference. So hopefully many of you have been, or if you haven't, you really should check it out. It's really a fun time, and there's a lot of learning that takes place and a lot of sharing. So the overview over the next half hour or so is really to bring to light some of the more common ENT problems that patients with ED face. ENT, of course, stands for ear, nose, and throat. And listed there are kind of the bigger things that we'll touch on. With regards to the ear, cerumen buildup is a very major issue. You can also get infections of the outer ear, known as otitis externa. And from the nose, we'll talk about sinusitis, allergies, and nasal obstruction, which can be related to crusting or actually rocks or concretions in the nose that are just large crusts that have solidified over time. As far as the throat, we'll talk about hoarseness and some dental issues as well. So let's begin first by just giving you a few of the references. I've published a few of these papers with Tim Fate and a few other authors over the years where we look specifically at nasal or rhinologic problems in ED and also characterize a lot of the head and neck problems and quality of life that patients with ED experience in that first publication that you see in 2007. Earlier on in 2004, there was another paper that I will be referring to throughout this talk by Shin and Hartnick that looks specifically at ear problems. And so as you know, ED is not a very common thing. So it's only been over the past 10 years or so that we really paid closer attention to what some of the objective and subjective findings are in patients that have the EDs. As far as starting first with the ear, I think it'd be worthwhile just to get a sense of the overall anatomy of the ear. Often, as far as the ear goes, we talk about ear infections and inflammation. And the ear can be divided into three compartments: the external ear, the middle ear, and the inner ear. The inner ear houses the organ of hearing and some balance functions, so rarely are we going to be talking about infections there. When you have a middle ear infection or fluid in the ear, we're really talking about inflammation or fluid that's present around the hearing bones in the middle ear space. I don't know if you can see my mouse here, but this is the middle ear space, deep to the eardrum. So if you stick your finger in your ear, you're really putting it in the canal, which is the outer ear or external ear. And at the depth of that canal is an eardrum that then separates the outer ear canal from the middle ear space. Then both the middle ear and especially the outer ear can be involved with issues related to ED. When we did our exam of several tens of patients over the past several years at the family conference, what we found is that up to 40% of them did have some visible deformity, call it, of the outer ear, and that's what the picture there shows. The patients often presented with a cup type of ear, and often when you had an outer ear abnormality, this did signify something that could be going on within the other parts of the ear as well. 30% of patients or more really complained of cerumen blockage. And this was on our exam. We even noticed problems with cerumen or wax. And we think a lot of that has to do with the fact that the secretions or anything that's made in the body of patients with ED often is dry because of the lack of certain glands and so on. 13% of patients also had stenosis or an actual physical narrowing of the ear canal, and that also would further exacerbate problems with wax impaction and so on. 1% of patients actually had fluid deep to the eardrum in that middle ear space that we talked about, and I'll touch base on what the significance of that can be in a moment. So on physical examination, 26% had that outer ear abnormality. 21% of patients actually already had tubes in place. When we talk about placing tubes often in children's ears, but we could do that in adults as well, that eardrum that separates the outer ear from the middle ear space is punctured with the patient anesthetized, and that eardrum is we then put a tube into the eardrum to help any fluid that might be trapped in the middle ear space escape out into the ear canal. Fluid in the middle ear space is significant because, as I said, that's where the hearing bones live. And so if you have fluid or anything that can disrupt the movement of those bones, you really will get a significant dampening of sound. And what that translates to is a hearing loss. And that's why we pay close attention to fluid in the middle ear space that does not get better. We also saw, again, stenosis or narrowing of the canal, and also some dermatitis or inflammation of the canal, which can even progress to an actual infection. As far as hearing test results, up to a third of patients with ED, and this really is compared to 5 to 15% of the general population, had an abnormal hearing test. That can happen for a variety of reasons. That can stem from the ear canal itself, all the way through to the middle ear, which we just spoke of, and even problems with the inner ear. I think as far as ED goes, the predisposition here is blockage at the level of the ear canal because of narrowing, because of dried out wax, or then potentially because of fluid that's accumulated in the middle ear space. As far as the symptoms that patients actually complained of, we asked these patients that we were interviewing to rate the symptoms of various ear problems from none, meaning 1, or severe and impacting their daily life, a 4. And the one that seemed to stand head and shoulders as far as problematic over most was the cerumen or wax impaction. Again, you're predisposed to that when you have a narrow ear canal, and again, in ED, the wax that's made is drier than usual. That, again, can also impact hearing. So cerumen impaction is one of the more common problems in ED. It can manifest as hearing loss. It can also cause itching and a drying sensation, and it can increase the risk of an actual infection or inflammation of the outer ear canal, also known as swimmer's ear. So how do we manage earwax? How do we get rid of it? First, there's not a lot generally speaking, that the patient can do to physically remove it. You hear about a lot of things that people will try, from candling to putting keys in their ear canal to a lot of different things, hairpin, you name it. We've probably heard of it, just to get that wax out. And the best way to have that cerumen or wax removed is to see an ENT doctor or a family doctor. Often if you go to a PCP, they'll try to irrigate out the ear canal with the wax that's being shown in the lower picture there, or they'll sometimes use a ring curette to try to scoop out the wax. If you see an ENT, almost invariably will take a more controlled and precise approach to having the wax removed, and will actually use an operating microscope to look into the ear canal and physically remove the wax with a variety of different suctions and curettes. When you irrigate, they usually put warm water irrigation in there to try to blow the wax out beyond the side of the irrigation. Sometimes different types of drops are also used, from hydrogen peroxide to other cerumen excites drops that are aimed at softening the wax so it does fall out more easily. As far as prevention, the first thing we would remind people is not to use Q-tips, whether you have ED or not. It's not a good idea to try to take a Q-tip and try to swirl out the wax, because even though you feel like you're swirling within the ear canal, invariably the tip of the Q-tip is pushing the wax further into the canal more deeply, where it can actually injure the eardrum or rest against the eardrum and actually have more problems than it did initially. Mineral oil drops, half-strength hydrogen peroxide can also be used to soften the wax and try to keep the ear canal healthy. Otitis externa, this is an inflammation or infection of the outer ear canal, or the outer ear itself. It's also known as swimmer's ear. This can be related to local trauma that becomes inflammation and then possibly infection. The signs and symptom of this is a painful ear that moves, especially when you grab the pinna, or the outer ear, the part that's on the side of our head, and kind of tug on it. If you have some pain when that happens, that can signify inflammation or infection of the outer ear or ear canal. This can also be accompanied by drainage, because once you get an infection, often purulence or pus can follow. As far as otitis externa prevention and treatment, the key here is to keep the ears dry, to have the wax managed as I just commented upon. And often we'll recommend for people who have a predisposition to this problem, or who've had ear infections, otitis externa, in the past, to try to keep the ear canal dry after swimming by placing some alcohol-type drops in there, Vosol, isopropyl alcohol, and so on. Generally, I would not recommend this until an ENT doctor or a family doctor has approved it, because you want to make sure that the eardrum is intact before you put something like alcohol into the ear canal, which otherwise can be irritating to the middle ear space. Antibiotic drops are then used once the diagnosis of otitis externa or outer ear infection is made, and sometimes the ear can get so swollen, the canal can, that the drops actually won't get in. In those cases, we will actually put a canal wick, which is this little wick that we place using a microscope into the ear canal, which then will wick the antibiotic drops deeper into the canal so that they can be more effective. Otitis media. This is inflammation or infection of the middle ear space, coming from media. And this is, again, that area that's deep to the eardrum, but away from the inner ear space where the hearing bones are. This is an increased risk in children with cleft palate, and generally kids in general are more predisposed to otitis media than adults are, due to some anatomy variations that kids have when compared to adults. And many kids will outgrow ear infections. This is a run-of-the-mill ear infection that you hear people talking about. As they grow, and as the anatomy of a tube called the eustachian tube, which connects the ear to the back of the nose, changes with growth. Based on several of the studies that are out in the literature, it does seem that patients with the EDs do have an increased risk of middle ear infections as well. And again, you'll want to work with your primary care doctor, and then when appropriate, a referral to an ear, nose, and throat doctor to manage otitis media. But the treatment for this is usually antibiotics, and once there's a certain threshold of recurrent infections that it's reached, or if the fluid that often accompanies these infections does not resorb over time, an ENT may recommend that tubes be placed in the ear. Again, when we place the tube, we essentially make a small hole in the eardrum and let the fluid that's trapped behind the drum then more easily escape. When you do this, it helps resolve the fluid, resolve the infection, and often resolve the hearing loss that's so important, which often accompanies this type of problem. Again, the hearing loss that patients have can be categorized into sensory or conductive. Sensory hearing loss is what we talk about when we talk about hearing loss associated with loud noise exposure or aging or a nerve type of deafness you may have heard of. The more important one in this setting that we're speaking of is a conductive loss, which can happen because of abnormalities of the ear as far as shape, because of wax or cerumen blockage, because of cholesteatoma or cholesteomata, which are really just epithelial cysts that can occur, and also, notably, because of ear fluid that can build up in the middle ear space. Now, if you're an adult and you have an ear infection, as annoying as it is, we're actually more tolerant of having a hearing loss that's associated. With kids, though, you can imagine hearing plays a very major role in our speech development, and therefore we are far more aggressive in making sure that the fluid that builds up in the middle ear space after infection over time, and usually in short order, meaning weeks or a month or so, resorbs. And if it does not, we really get concerned that it can impact the child's hearing, and eventually speech development can be affected. So we're a little more aggressive in kids when it comes to this type of problem than we are in adults, and that's the significance of having ear issues in kids. So let's move on here to nasal findings as well. When we looked at the patients that we examined a few family conferences ago, we noticed several issues related to the nose. On examination, there was moderate to severe dryness in the nasal cavity and crusting. Often the crust would be so large that we coined the term rhinoliths, which is like rocks or nasal rocks within the nose that are these concretions of debris and mucus that is normally produced. Up to 23% of patients were also noted to have a moderate to severe septal deviation. The septum is a structure in the middle part of the nose that's made up of bone and cartilage, and it divides the nose into left and right sides. And the significance of it being deviated or bent in one direction or the other is that it can cause nasal blockage, as can crusting, dryness, and the rocks as well. When you look at someone with ED, often you'll see a flattened nasal bridge known as the nasal dorsum, and this occurred in about 12% of people that we examined, and sometimes it can be even more severe in the form of a saddle nose deformity, which can impact breathing as well. Interestingly, we thought that patients with ED may have a disturbance in smell, because smell lining is actually derived from ectodermal tissues, but when we administered scientific questionnaires and tests looking at smell, actually most people had a very keen sense of smell, so that was a little bit of a surprise, but we were happy to find that. As far as the nasal symptoms, meaning what did the patients actually complain of, over half of them really had problems with nasal dryness and crusting and blockage. The concretions or rhinoliths I mentioned also were up to about 40% of patients, and another 40% had problems with moderate sinus infections or allergies as well. 35% of patients had problems with epistaxis, which is nosebleeds that they characterized as moderate to severe. Nosebleeds happen from trauma, high blood pressure, being on blood thinners, and specific to ED, we think they're at a higher occurrence rate because they do happen in the setting of dryness, and when these concretions or rocks are shifted around or if they're picked at to get out, then they can abrade the already dry lining and you can have a bad nosebleed. 26% of patients that we spoke to had greater than 3 courses of antibiotics a year for sinus infections. Many of them were taking decongestants or allergy medications known as antihistamines and nasal steroid sprays as well. As far as the symptoms that really came to the fore as far as most problematic, as you would imagine, like the ear, it's the dryness issues. So dryness, crusting, and concretions were moderately severe as far as how bothersome they were to the patients. So let's talk a little bit about them. First, the nasal obstruction in ED often has to do with a large amount of the thick mucus, nasal crusting, and rocks that are created. Young children are obligate nasal breathers. That means before about the age of 3 years, we breathe preferentially through the nose and not the mouth. So this can be more significant to very young children. Interestingly, the study that we did actually showed that the rocks or the dry concretions actually got better with increasing age, so that was good news. Here's a picture of what we mean by rhinoliths or concretions. On the left is a rock you can see wedged into the nasal cavity, and you can imagine if you try to get that out by irrigating or picking, or even when an ENT may take it out, you are disposed to a little bit of bleeding because it's kind of stuck up against the already dry lining. As far as prevention of nasal obstruction, I think as with the ear and as with many scenarios in dealing with ED, the key is going to be humidification and moisture. So we recommend that you have a humidifier near your bedside. You don't want to take any additional medications in the humidifier, or otherwise that could be drying. And especially in the winter months when things are particularly dry and kind of scabbing in the nose, we'd recommend that you use nasal saline drops frequently. You can make these up on your own or buy them. They can come in different packages and so on. Half a teaspoon of salt with a half a teaspoon of baking soda would make a nice nasal irrigation in about 4 ounces of warm water. Moving on to nasal blockage, sometimes the crusting do need to be removed, and that's what we recommend to see an ENT doctor. We have different tools, including mini nasal telescopes that will help us visualize exactly where the rocks and the crusting is located to gently remove it. And it's another good idea to take it out, not just because it's bothersome, but because the concretions and crusts can actually block over sinus passageways. This can be experienced as nasal blockage, so you can't breathe well with it, but it can also set you up for sinus infections. Sinusitis is a sinus infection which occurs when the dry mucous membranes and crusting kind of block over the natural sinus drainage pathways, and the mucus that's normally made in the sinus is then trapped and can't get out. This then secondarily can become infected. People can experience sinus infections through symptoms like nasal discharge that's green or yellow, headache and pain, nasal blockage, and sometimes in the acute setting, you can even get fevers. Children actually rarely complain of headache and pain with sinus infections, but they may have a persistently runny nose that is yellow or green with discolored drainage, and cough can be a symptom of sinus infections in children as well. How do we treat sinus infections? First, we try to treat the culprit here, which often is the nasal crust, so we try to have that removed. We may turn to nasal irrigations, and certainly in the setting of an infection that's moderate or severe, we would recommend antibiotics to help it settle down. Sometimes nasal steroid sprays can be used, usually even after an infection, just to help the lining decongest and to work better. If you're going to use a nasal decongestant spray, which are actually available over the counter so that you can breathe better during a sinus infection, you want to remember that these sprays can be addicting, and they can actually over time cause a rebound nasal swelling that'll actually make things worse than when you started, and it's thought that you shouldn't use them for more than 3 to 5 days of continuous use. Allergies also are a major underlying risk factor for recurrent sinus infections, and so we would recommend having the allergies treated as well. As far as immune deficiency or problems with the immune system and allergy, we do suspect that these things can be risk factors for sinus infections as well as middle ear infections or otitis media. You have a marked increased amount of infection or severity of infections, then this may prompt an evaluation of the immune system, and you can see an allergist about that or start with your family doctor. We do think that some types of EDs are associated with an immune deficiency, and it does seem that there's a higher prevalence of allergies in the ectodermal dysplasias. We don't know why this is, but it does seem like that's the case. As far as how we treat allergies, first thing is to first find out what you're allergic to. That can occur based on results of blood testing, or you can also have more traditional types of allergy testing, which include skin pricks and so on, looking for reactions at the skin level. The treatment then is to avoid what you're allergic to once you've done the testing, and then medical management consists of antihistamines or anti-allergy pills, and also nasal steroid sprays. You've heard of Flonase, Nasonex, and things like that. Nosebleeds, we have to talk a little bit about this because, as I said, it is a risk factor having the concretions and the dry mucous membranes and crusts. The prevention, again, is the nasal saline drops, maybe using some petroleum-based antibiotic ointments like polysporin or neosporin. We advise to use those a few times a day to keep things moist. And then I think another thing that you want to know is what to do when you get a nosebleed. So this is contrary to what you're even told often by other doctors or even in the emergency department in some places, but the true treatment for an active nosebleed is you can spray some of the Afrin I talked about, or a decongestant spray. But what you want to do is you want to sit upright, put your chin down to your chest so that the blood would run down and out of your nose rather than back and into your throat, because blood, when you swallow it, can be nauseating. And you want to firmly press the fleshy part of the nostrils together into the middle part of your nose, and you want to hold them there for 5 to 10 minutes by the clock. That will stop over 95% in nosebleeds. And then if these measures fail and you have a persistent bleed for 10 to 15 minutes, then you should go to the emergency department to have it looked at, and sometimes we'll do things like place packing or sometimes even cauterize the bleeding nasal area that is found to be the culprit. So let's move on. We did the ear, we did the nose. Now let's move on to the mouth and throat. Based on our studies and others in the literature, some of the physical findings in ectodermal dysplasia that I think are well known to the group, but they include abnormal teeth in the large majority of kids, dry mouth, hoarseness, and throat irritation, also known as pharyngitis. Interestingly, other unrelated things are alopecia or missing hair of the eyebrows and scalp, protruding lips, and eczema. As far as the throat, one of the leading problems is difficulty with chewing and swallowing due to abnormal or conically shaped teeth. Due to decreased saliva production, this also makes swallowing a problem, and we try to treat this by reminding patients to increase their fluid intake during meals and to often use lemon drops or anything that's sour to try to help promote salivary flow, and then, of course, to take good care of the teeth that you do have. As far as hoarseness, this can be related to lack of lubrication of the larynx. You can see the theme here, dry secretions, and that's what we target. We recommend humidifiers, increasing fluid intake, avoiding irritants like allergens or cigarette smoke, and certainly persistent hoarseness should be evaluated by an ENT specialist because other things, including problems with vocal cord movement, vocal cord polyps or nodules, also can occur. So what did the patients complain of when we looked at the oral symptoms? Again, 1 is no problem, 4 is extensive or severe. The dental work was really front and center. And I think a lot of this has a functional impact, not having teeth or teeth that are conical or abnormally shaped. But, of course, it also is going to have, I think, a psychological impact as far as the cosmetic appearance of it and so on. Cleft lip or palate, this is associated with several ED syndromes as well, AEC, EEC, etc. And this can be related in ED syndromes as well as unrelated to ED as well. Problems that cleft lips and palates can lead to include hypernasal voice or air escape into the nose when you're speaking, articulation or pronunciation problems, and also an increase in ear infections because the tube that connects the ear to the back of the nose doesn't function so well when the palate has a cleft in it. These issues are usually managed in most centers in a multi-specialty team that includes a speech-language pathologist, often a plastic surgeon, an ear, nose, and throat surgeon, etc. Let's move on to quality of life. This was part of one of our papers that we did some time ago where we actually looked to see, I've identified all of these ear, nose, and throat problems and head and neck problems from the ear to the nose to the throat. We talked about some of the other issues that these can lead to. So what is the quality of life, just generally speaking, in patients with ectodermal dysplasias? And on this slide, what you're looking at is a Likert scale going from 1 to 5, where 5 is conditions that severely impact quality of life in all of these different domains: health, physical activities, daily work, bodily pain, energy, and activities. And what was interesting to us is that by and large, patients with ED actually had a very good quality of life, and they seemed to be very positive overall to how their issues were affecting them. So I thought that was also a very pleasant and somewhat surprising finding of the work that we've done. So in conclusion, patients with ectodermal dysplasias frequently experience ear, nose, and throat symptoms that can be quite troublesome to them. Most patients appear to have a good quality of life, and as I said, for example, the rocks and so on, many of these problems do get better as children get older because the size of the openings to the nose and the ear get larger, and that's something to kind of look forward to. You want to work closely with your primary care physician for appropriate referrals to specialists. This can include an ENT, speech-language pathologists, and allergists, as we talked about, oral surgeons, and plastic surgeons as well, depending on what aspect of the problem we're trying to get a handle on. So with that, I'd refer you to the NFED website for further questions, and we do have some time, so I think, Kelly, you want to open the floor to some questions, right?
Yes, absolutely. And if you have questions, you can chat your questions into the chat box, and we can address them. One of the questions that we've had at the office is it recommended for the sinus surgery for a deviated septum? Can surgery actually correct that problem for individuals that are affected by ectodermal dysplasias?
That's a good question. So, yes, it can. Deviated septum causes nasal blockage. And so the first thing is you want to make sure that, that's the actual diagnosis that we're dealing with. So when a child comes in with nasal blockage, you have to have a very thorough exam to make sure that it is a deviated septum that's causing the blockage. As an example, it could be the concretions or rocks we talked about. It could just be crusting. And in kids, often adenoid tissue is a bigger culprit than even a deviated septum. Certainly in the over 18 age group, the main cause of nasal blockage, worse on one side than the other, would be a deviated septum. But in kids, it's actually hypertrophic or swollen adenoid tissue, ectodermal dysplasia or not. That's probably the most common cause. So, yes, we have good treatment options for all of the things that can be causing the blockage, but you want to make sure we systematically look into what those are. And then, certainly, if it is a deviated septum, surgery has been shown to be very effective in helping the patient breathe better.
Okay, great. For someone that has a difficult time with swallowing, what would you recommend for them, generally speaking? What should they try first?
For swallowing problems?
Yes.
So in this case, you want to make sure that, you have adequate hydration during meals. So you want to always make sure that to encourage your child to drink lots of liquids during meals, making sure their throat is dry, again, with a humidifier at the bedside. I think can't be overstated how important that is. And then trying even afterwards for problems of swallowing or dry throat, sialogogues or things that will promote salivary flow, like sour things, lemon drops, and things like that. If you have persistent problems with swallowing, or, for example, if swallowing leads to choking or coughing spells, that may be a sign that you want to see an ENT doctor to make sure that there's nothing anatomical going on that could mean that the food or drink is going down the wrong passageway, leading to the coughing and sputtering if that happens during meals.
Okay, great. Is there any connection between hydration and the distinct smell that comes from the nasal rocks?
Yeah, I think the smell that comes is from dried up crusting or nasal rocks. And essentially, that dried up crusts are really the mucus that's made. And they actually have sugars and other things that, normal body fluid has. And so I think what the smell is that crust kind of hangs around, day after day. And bacteria that are normally in the nasal cavity will kind of overgrow onto that crust. And I think the foul odor that patients often experience is related to that overgrowth of bacteria. It's not necessarily an infection, although if you had a sinus infection, you also can have a bad taste or smell in your nose and mouth as well because of bacteria. But often it's just the crusting in and of themselves. For that, we talked about humidification, irrigation, and seeing an ENT to have them removed if they're significant.
Okay. I'm going to just scroll through our questions here.
Okay.
Apologize. So for the nasal rocks, just a daily saline drop is a good treatment?
Yeah, for kids, a saline drop is fine because they won't tolerate doing much more. But if the child's older, certainly into the teenage years or even as adults, saline irrigations are probably better. So, you can get saline into the nose in a variety of ways. You can just put drops in like we do for kids. You can have a spray bottle like ocean spray or saline spray. And then more aggressive is a higher flow, higher volume technique where you could use something like the neti pot or a sinus rinse bottle that actually squeezes higher volume and higher pressure stream of saline into your nose. So the idea of that stream is that you're going to have a little more force behind it, and hopefully it'll kind of blow those crusts out of the nasal cavity. When you do irrigations or neti pot or even saltwater sprays, you want to try to hold your breath when you're doing them. You shouldn't feel like you're drowning or like, you're inhaling it. I usually tell patients to lean over a sink with their head down into the sink, get a squeeze bottle or a neti pot, take a big breath in, hold it, and then irrigate your nose with 4 ounces of water. So stop, take a few breaths, and then do the other side. And when you do it, we get these questions a lot as well. But when I irrigate, it comes back down the same side on one side, but when I do it on the other side, it goes all the way around. It's probably not that important whether it goes all the way around or comes down the same side or even comes out your mouth, to be honest. It's just the physical act of doing that regularly, once or twice a day, that I think is going to keep that mucous membrane bathed in some moisture, so moist and healthy, and it'll help propel any mucus along so that it doesn't get hung up and form crusts.
At what age can parents start the saline drops with their children?
Saline drops are safe even at a young age. In fact, often when kids have colds, I'm not a pediatrician, but I remember when our kids were young, the pediatrician would tell us to put saline drops in the nose and then suck them back out, with a bulb syringe, those blue bulb syringe that you use for kids. So, check with your pediatrician, but I think even into the early part, before even a year old, you can use the saline drops.
So how do families know when it's a difference between they've got this typical nasal rock sinus problem going on, or if it's a sinus infection? How do they distinguish so that they're not on antibiotics consistently?
Right. It can be hard, I think, as a patient or a family member trying to differentiate some of these things. But sinus infections usually aren't subtle. And they don't kind of grumble along indefinitely. So a sinus infection, you might think of it as kind of having a cold. It's episodic. The symptoms are quite severe for a short period, like a week or so. Again, they're characterized by discolored nasal drainage, the person being very sick, having a fever, having some pressure in their face, not being able to breathe and being pretty miserable. Now, the rocks can cause some of that stuff as well, but generally the rocks and crusting is a duller type of symptom complex where they might have a little bit of congestion, maybe a little bit of nosebleed on and off, but overall they feel fine. They don't feel like they have a cold, and they don't feel sick. If you have a sinus infection, you'll feel sick.
Okay. That'll help with my own personal knowledge.
There you go.
These are great questions that you all are submitting. And we have, lots of time left. We have about 20 minutes and a couple more questions. But if you have questions, keep chatting them in. So our next question is, someone's son has very large boogers, and sometimes they're larger than his nose and painful when they're coming out. How can they deal with those?
Those ones are probably helpful to see an ENT about. So often what we'll try to do when we're taking those out is, you try the irrigations and so on, but sometimes they can really be wedged in there. So in that setting, depending on how old the child is, we can actually go in with an endoscope or a telescope and break up the rocks a little bit and then take them out.
Okay. And could you go over again with the smell of the sinuses and from the nasal rocks, how to treat that?
How to treat the nasal rocks?
The smell, the odor that comes from the nasal rocks.
Oh, so that's just the overgrowth of bacteria, and the best way to treat that is to get rid of the rocks or to try to keep the crusting to a minimum. So again, it comes back to hydration, ocean spray or saltwater mist, sprays and irrigations to try to keep the mucus in one's nose moving so that you don't get stagnant mucus flow and then the concretions or crusting that will get dried out and form rocks over time. So often what happens is, you'll get into a situation where you're behind the 8 ball a little bit and you have these large rocks and you can't deal with them. On rare occasion, I've even taken patients to the operating room because it's just unpleasant to do in the clinic. We'll give them a good thorough clean out, kind of reset the clock a little bit, and then get them to be very almost religious about irrigations and keeping things moist. So the best treatment there is to try to avoid getting behind the 8 ball with too much dryness and too much of the crusting.
Okay. Our next question is on hoarseness. For people that experience severe hoarseness and completely lose their voice for a period of time, how can they treat that?
Okay, so there's different causes of hoarseness. Some of it can be just hydration related, as we're saying. Sometimes you can have vocal cord polyps, vocal cord movement issues as well. And you can even have laryngitis or just an inflammation or infection, often viral, of the voice box or larynx, which can affect the vocal cords. So most of those things are self-limited, meaning after a week of laryngitis, your voice will come back. While you have it, we tell you to be on voice rest and just kind of, not use your voice so much and speak in a normal voice. Don't whisper and don't yell. But how you treat it and the outcome of it really depends on which one of those entities it is. From an ED standpoint, I would focus on the dryness, and then if there's persistent hoarseness that does not get better, or let's say it's happening very frequently, then that may be something to see an ENT about, so you can look down and make sure it's not an anatomic issue and that the vocal cords appear, meaning look normal and function normally.
Okay, very good. Hope these questions, or rather Dr. Sindwani's information is answering your questions. We ought to remind you that this is all information being presented to you, and you should follow up with your own ENT to discuss the treatment options and suggestions that Dr. Sindwani has shared with us tonight. I scrolled through and I think I've missed some questions, so I'm going to go through there, and here we go. Croup. Someone has a daughter who has 3 to 4 episodes of croup a year. Is that common in ectodermal dysplasia patients? Do you know?
Not that we know of. We don't know why some kids are more predisposed to croup compared to others. I don't know of any association with ectodermal dysplasias, though.
Okay. I don't see. Can you see the first part of that question? Not how you pronounce that.
I can't see that.
Don't see the questions. Okay. I will copy that and send that to you.
Okay.
Let's see if that works.
Okay. My daughter has EEC, that one, Kelly?
Uh-huh.
Without cleft palate. So the question is, my daughter has EEC without cleft palate. She does have velopharyngeal closure insufficiency issues. Is this common in EDs? She is also prone to 3 to 4 episodes of croup a year. Oh, so this was the croup question. So I don't think the croup is more common. There's varying degrees of cleft palate. So you can actually have a submucous cleft, which means that even though there's no physical cleft in the palate, you can have still a dysfunction, essentially, of the way that the palate works. And velopharyngeal closure problems, which means that the soft palate doesn't reach up and close off the nose when we swallow and talk sometimes. So you can have air escape up into the nose or even liquids that can go up into the nose when you have that issue. And as we know, cleft palate and other palate problems do run in some forms of ED, including EEC. So the answer to the question is yes, there is an association with those things and EEC.
Okay. Is there a relation between ectodermal dysplasia and vertigo? This isn't a question that I received often at the office. Are you familiar with that?
Not that we know of. So vertigo, there's different forms of vertigo and different causes of it. But when you have a spinning sensation, like the room is spinning or you're spinning, an actual physical sensation of movement, often we suspect that it can come from the inner ear. And we went through the anatomy of the ear during my talk about how there's outer ear issues, middle ear issues, and so on. As far as we know, there's no inner ear connection to the EDs. Certainly if you had fluid in your middle ear space, you could feel imbalanced or have a fullness sensation in your head or ear, but you should not experience true vertigo or that illusion of spinning sensation of movement that vertigo is really defined as. So I don't think there's any association that we know of.
Okay, wonderful. Someone has their son who's 8 blow bubbles through his nose in a large bowl of water when in the shower to clear his nasal blockages. Is that okay?
Yeah, that's fine. Anything that works. I mean, at 8, it's hard to get them to do different things, but I think blowing out is good. Maybe trying the drops as well, or ocean spray to keep things moist is also a good idea.
Okay, great. I think you mentioned earlier a cool mist humidifier is the preferred type of humidifier.
Yep, that would be great. Anything to increase moisture. So again, most of us don't recommend, having different medications in there and things like that. I think it's really just the moisture that's going to help. Another trick is to get antibiotic ointment, especially in the winter months, and just to place that in the front part of the nose, especially before you go to bed, because as you lie back, it'll melt and coat the whole nasal passage.
What about that stuff, I'm blanking on the name, you rub it on your chest, it's been around for years.
Oh, the Vicks?
Yes, Vicks,
yeah.
Thank you.
I mean, I think it's fine to use on your chest. I don't know that it actually has a major advantage, other than it does give the sensation that things are more open. So I think if, your child does better with it, I think it's okay. I don't think it's doing a lot necessarily, but it does give the sensation that your nasal passages are more open. There's menthol in it, which has been shown to give that appreciation to somebody.
Okay. Is it common for sinus infections to test positive for strep? Whenever her son gets a really foul smell from his nose, he always tests positive for strep. Then the secretions that come from his nose has a very sticky, smelly viscosity.
Yeah, so the common agents that cause sinus infections include strep, there's some staph, and a few other bugs that we have as well. These are all common infections that can affect the sinuses and, of course, the tonsils and throat as well.
Okay. And it looks like that's all of our questions in our chat box. How often would you recommend that individuals that are affected by ectodermal dysplasias and or parents who have children that are affected by the condition see their ENT? Once a year, every 6 months, only when they have a problem?
Oh, I think a lot of that just depends on the type of problem that you're experiencing. The EDs are a real spectrum, and so it just depends on the number of issues and the severity of issues that you're having. Sometimes you may, see an ENT just once, and if everything checks out fine, you may never need to see that person again. And other patients, if you have ongoing issues, might need multiple visits, procedures, surgeries, tubes, cleft palate repairs, all these things that we talked about. So I think that really should be individualized based on the types of problems you have and how severe they are.
Okay, great. Thank you so much for sharing your knowledge and expertise with us. I know I mentioned earlier you're our expert on snot. You truly are, but you're so much more than that.
No problem.
You're always very helpful to our families and the staff when we have questions in order to be able to educate families and other practitioners that are not familiar with the ectodermal dysplasias.
Yeah, and I think that's part of the issue here is that often you will go to a PCP or even some ENTs and they may never have heard of it, So they themselves may not know, what to look for or what some of the issues could be. And so that's why, over the past, as I was saying, 5-10 years, we've had quite a few studies out there, and sometimes it may be helpful to even go in with those studies to educate yourself. And then, as long as you have an open relationship with your doctor, you may be able to educate that person as well so they know what to look for. And so it's good that everyone's interested in learning and trying to help themselves over these issues.
Okay. Someone has chatted in, is von Willebrand disease in relation to ED and more frequent nosebleeds? Are you familiar with that condition?
Yeah, so von Willebrand's disease is a problem with different factors in the blood. It is not associated with ED as far as I know. but it is associated with frequent nosebleeds. So that's a totally separate thing from the mechanism or the reason for nosebleeds that we're talking in ED. So if you have von Willebrand's disease or hemophilia or some of these other blood problems, your blood doesn't clot so well. So it doesn't necessarily have to do with dryness or concretions or crusting. It's just you're predisposed to bleeding from any part of the body that's traumatized, and that often includes nosebleeds as well.
Okay, great. Thank you. Are there any other questions that you may have for Dr. Sindwani tonight? Well, we certainly want to thank you for joining us and hearing his presentation. Don't forget, you can access the recording. It will be available in about a week. It will be available on our website, and a link to the recording will be sent out to you by email, and it's on a hosted site for a while, and then it goes to our website. So that will be available to you, and if you have additional questions on this topic or any other topic, just contact the NFED. That's certainly why we're here, and you can do so by email at info@nfed.org, or by calling the office at 618-566-2020. And if our staff can't answer those questions for you, we'll certainly reach out to the experts that can. In the meantime, we want you all to have a great evening. Dr. Sindwani, thank you so much for taking time out of your family's schedule tonight to be with us and continuing to educate us on the...
No problem, Kelly. It's my pleasure.
Thank you. Good night, everyone.
Good night.
Thank you. Please stand by.